Okay, if you understand what high-dose dopamine does, if you understand what Levophed does, if you understand what neosynephrine does, then it's really easy to understand what nipride does, because nipride is the exact opposite of all those other drugs. When we use nipride, the big thing that we use nipride for is to decrease the systemic vascular resistance. So it's a massive vasodilator, specifically an arterial vasodilator. It does have some preload effects, but most of nipride's magic is actually on the afterload side. So when we use it, we'd use it in anybody who we want to decrease their systemic vascular resistance. So we might use it in people who are in hypertensive crisis. We might use it in people who are in congestive heart failure, who have a high SVR and a high blood pressure. We might use it in anybody who's got any increase in their systemic vascular resistance for any reason. The big thing to remember about nipride is we don't want to give it to people who have decreased cerebral perfusion. We also don't want to give it to people who have a history of hypersensitivity to nipride. When we talk about using nipride, we want to use it in caution with people who have renal disease, because remember that when nipride breaks down into cyanide. The way that nipride is broken down in the body, there's actually two stages to it. The first stage is it actually breaks down in the liver into cyanide, and then the kidneys actually break it down further and excrete it. We have to have a good liver and good kidneys in order to give a patient nipride. And obviously you can see why that's kind of a problem, because most of the time when people are so sick they need nipride, they usually don't have good kidneys and they usually don't have a good liver. So for those patients, we usually try to avoid nipride, but when we do use nipride, we always use it on a very short-term basis, usually more than a couple hours. And remember, again, when we're talking about nipride, remember that we want to get patients off of it as quickly as we can. And finally, the last thing, when we talk about dosing a nipride, remember that when we're dosing nipride, we usually give nipride at doses of anywhere from 0.3 to 6 mics per kilo per minute. And when we're giving nipride, we titrate it slowly. And remember that nipride is like a light switch. If you turn nipride on, it works. If you turn it off, it goes away. One of the most common things that people do wrong with nipride is they titrate it too quickly. They titrate it up. And remember that a lot of times when we're given nipride, you've got to get several cc's in just to get down your IV line and actually get to the patient. A lot of times people are impatient, and so they go up on the nipride, nothing happens, so they go up again and nothing happens, so they go up again, and lo and behold, the patient's blood pressure tanks. Well, remember, if we take our time and we titrate it slowly, we'll avoid those bad effects with nipride. So we want to titrate it slowly, and remember also that even if you're titrating slowly, sometimes patients just have a threshold where you're titrating and nothing's happening, and then boom, all of a sudden their blood pressure falls. If that occurs, then all you want to do is slowly titrate your nipride back down. Don't shut it off, just titrate it slowly back down. Remember, nipride's like a light switch. You turn it on, it works. You turn it off, it goes away. We don't want to titrate it inadvertently, over-titrate it, dump the patient's blood pressure, and then turn it off and shoot their blood pressure right back up. So we want to be very judicious with our titration of nipride. Titrate up slowly, titrate down slowly. When we talk about nitroglycerin, this is a drug that most of us are really familiar with giving. We've given lots and lots of it, but just a quick review. Remember that the big reason why we use nitrates is to reduce preload at low doses, but remember at higher doses, usually more than about 80 mics a minute, we actually get a significant amount of afterload. So low doses of nitrates are really going to give us venous capacitance, are really going to increase the amount of blood that can sit in the venous system, but once we get over about 80 mics a minute and the higher up we go, basically nitro starts to have very similar effects to what nipride does. So when we talk about uses for nitroglycerin, obviously we can use it for angina, we can use it for CHF. We can also use it if we want to decrease the patient's CVP at low doses, or if we increase the dose higher, we can also use it to decrease the SVR, just like what we would use nipride for. And nitro is actually, with our realization of how significant nitro decreases the systemic vascular resistance at high doses, nitro has actually become really kind of a drug of choice again, and it's really started to replace nipride in a lot of places because we don't get the cyanide toxicity like we do with nipride. Now, it depends on the book you read, but some books say around 50 mics, some books say around 80 mics, but remember those low doses basically were decreasing preload by causing venous vasodilation. At those higher doses, anywhere from 50 mics or 80 mics, depending on the book you read up, then basically what we're doing is we're decreasing afterload. Now, nicardipine or cardine is another drug that we use a lot for the same reasons that we would use nipride or nitro. The big thing it does is it decreases afterload by dilation of the arterioles. Now, when we talk about this drug, Remember the way that nipride and nitro work is they actually convert to nitric acid, or I'm sorry, nitric oxide, which causes vasodilation. In contrast, nicardipine or cardine is actually a calcium channel blocker. So it offers us some advantages and some different ways to attack the systemic vascular resistance besides the ways that we do when we're using nipride or nitro. When we talk about nicardipine or cardine, remember we're going to use it for the same reasons. Anybody we want to decrease their systemic vascular resistance or decrease their blood pressure. The big thing to remember with cardine, and you could say actually the same thing about nipride, or you could say the same thing about nitro, is if we decrease the systemic vascular resistance enough that we decrease the blood pressure, then the heart is effectively going to increase to try and keep that blood pressure the same. So often when we're using drugs to vasodilate people, we also have to put them on beta blockers to block them from having an increase in the heart rate, especially like when we're talking about things like treating an aortic aneurysm or something like that. The other big advantage to cardine over nipride, again, is like with nitro, it does not cause cyanide toxicity. So we've really seen that nipride is really kind of, it certainly hasn't gone away. We still use nipride a lot, but not as much as we used to because of the fact that we can use nitro at high doses, or we can use cardine and not have to worry about the cyanide toxicity. When we talk about the dosing for cardine, usually we use doses of around 5 to 15 milligrams an hour, and obviously like all of our other vasopressors, we're going to titrate it to our blood pressure. Okay, one last drug that's worth mentioning when we're talking about things to decrease SVR is phenoldiprem or Corlipam. When we talk about phenoldiprem, the way that this drug works is this is actually a dopamine receptor agonist. And remember that when we have dopaminergic effects, we said that increases renal blood flow, and we said that also increases mesenteric blood flow. So when we use phenoldiprem to drop somebody's blood pressure, the way we're dropping their blood pressure is we're vasodilating all the arteries in their gut, and we're also vasodilating their renal arteries, which is causing an increase in renal perfusion. So phenoldiprem or Corlipam also has a diuretic effect to it. But remember, it's not going to be a quality diuretic. It's not like what we would use Lasix for, because while it does get rid of water, it's not going to get rid of a lot of other stuff. When we talk about reasons why we would use it, again, we use it in anybody that we want to drop their blood pressure. We use it a lot in pre-renal failure from renal stenosis to improve perfusion to the renals themselves, and we also use it to decrease the SVR. Now, when we talk about reasons why we would choose it, the big thing is like nitro and like cardine, it doesn't have the cyanide toxicity, so a lot of times we'll use that instead of using nipride. When we talk about the dosing, we usually start at doses of 0.03 to 1.6 micrograms per kilo per minute, and again, like all the others, we're going to titrate it to the blood pressure. Okay, this is just a quick slide here that's got all of our common pressors on it and a couple of our vasodilators. It just goes through and it looks at each one, does the heart rate, cardiac output, CVP preload, pulmonary vascular resistance, systemic vascular resistance, and renal perfusion. So I would highly suggest that whether you're taking the CTRN, the CFRN, the FPC, or the CCRN, you need to be intimately familiar with this slide. You need to know what each one of these drugs does. You need to know the effect that it has, because on your exam, typically what they're going to do is they're going to give you a set of hemodynamic values, and they're going to want to know that you know what the appropriate agent is to manage that. Now, when we talk about our hemodynamics, let's just quickly review our normal numbers, and then let's talk about how they play into various types of shock. Remember, we said a normal CVP, we said CVP was our measurement of preload for the right side of the heart because it's a preload number, we measure it as a mean, and we said a normal CVP is somewhere around 2 to 6. When we talk about the cardiac index, remember the cardiac index is the cardiac output that's been made specific for body surface area, and we said a normal cardiac index was somewhere between 2.5 and 4.2. Remember when we talk about normal pulmonary pressures, we said a normal pulmonary systolic is somewhere around 15 to 25. A normal diastolic is somewhere around 8 to 15. When we talk about a normal wedge, remember a normal wedge is somewhere around 8 to 12. And when we talk about systemic vascular resistance, we said that was somewhere between 800 and 1200. So let's talk about how all these things interplay when we look at various types of shock. First, let's talk about hypovolemic shock. When we talk about hypovolemic shock, what's the problem? Is it a pump problem, a pipe problem, or a fluid problem? Well, we all know with hypovolemic shock, it's a fluid problem. Because it's a fluid problem, because there's not enough fluid, what is that going to do to our central venous pressure? Well, obviously that's going to lower our central venous pressure. Hypovolemia is going to cause a decrease in our CVP. Well, remember when we said cardiac output was driven by three things? We said that it was driven by heart rate, and then the three things that go with heart rate are preload, afterload, and contractility. Well, if I don't have enough preload, then obviously that's going to decrease my cardiac output. So it's not surprising that when we're in hypovolemic shock, not only is our CVP going to fall, also our cardiac index is going to fall. Now, our PA pressure and wedge pressure are also measures of pressure in the arteries, and if there's not enough fluid to go around, then obviously both of those are going to be down. But the big thing that's going to be up in hypovolemic shock is our SVR, and we all know that. We've all seen trauma patients. We all know that when patients are hypovolemic, what do? They vasoconstrict. Well, if you have mass vasoconstriction, what does that do to your SVR? It goes up. So when we talk about the hemodynamic profile for hypovolemic shock, what we expect to see is that our cardiac index is low, all of our pressures are low, and our SVR is high. So again, our cardiac index is low, all our pressures are low, our SVR is high. That is the classic example of hypovolemic shock. Now, what about when we talk about neurogenic or anaphylactic shock? Well, with neurogenic or anaphylactic shock, the big thing you need to remember with those is the hallmark thing, the thing that diagnoses neurogenic or anaphylactic shock is a decrease in the SVR. So with most types of shock, we get vasoconstricted. When we're in cardiogenic shock, we vasoconstrict. When we're in hypovolemic shock, we vasoconstrict. But when we are in neurogenic or anaphylactic shock, that is hallmarked by a decrease in the SVR. Now, when we talk about the other things that we see with those patients, because they're so massively vasodilated, obviously all of our pressures are going to be low, and because all of our pressures are low, we're also going to have a decrease in our cardiac index. So the way that we identify a neurogenic or anaphylactic shock is everything is low across the board. CVP is low, PA pressures are low, wedge pressure is low, cardiac index is low, SVR is low. So everything is low. Now let's talk about cardiogenic shock. When we talk about cardiogenic shock, remember that we have two kinds. We can have right-sided cardiogenic shock or we can have left-sided cardiogenic shock. Well, with right-sided cardiogenic shock, the whole problem is the right ventricle is failing. So remember our little rule is anywhere there's an obstruction, everything behind it's going to be high pressure, everything past it's going to be low pressure. So with cardiogenic shock from right-sided failure, the CVP is going to be high, but the cardiac index, PA pressures, and wedge pressure are all going to be low. Well, because the cardiac index is low, because the PA pressures and the wedge pressure are low, compensatorily, what are we going to do? We're going to vasoconstrict to keep our blood pressure up. So when we talk about right-sided cardiogenic shock, the hallmark of that is the patient has a high CVP, has a low cardiac index, low wedge pressure, low PA pressures, and has a high systemic vascular resistance. Okay, now what about cardiogenic shock from left-sided heart failure? Well, with cardiogenic shock from left-sided failure, we know that the obstruction is the left ventricle. So we know everything behind it is going to be what? Is going to be high pressure. Everything past it's going to be low pressure. So when we look at left-sided failure, when we start with the CVP, if the left-sided failure is bad enough that it's actually caused blood to back all the way up into the lungs, all the way into the right ventricle, and all the way up into the central circulation, we're going to see that the patient is going to have a high CVP. Now, if we catch somebody early enough in cardiogenic shock, we may actually see that they don't have an increase in their CVP, but most of the time, most people in left heart failure are also going to have right heart failure. So we're probably going to see that the CVP is going to be up. Now, obviously, the cardiac index is the reflection of cardiac output, and obviously, if the pump is the whole problem, cardiac output is going to be down, so we expect their cardiac output is going to be down. And because we know the obstruction is the left ventricle, we know blood is going to back up in the left atrium and the lungs, so we know both the PA pressure and the wedge are going to be up. Finally, we know that because the patient is not actively contracting well and is not perfusing well, the body is going to vasoconstrict. So when we look at the hemodynamic profile for left-sided heart failure, what we see is the CVP is probably going to be up, the cardiac index is definitely going to be down, the PA pressures and the wedge pressure are definitely going to be down, and the systemic vascular resistance is definitely going to be up. Okay. Let's talk about ARDS. When we talk about ARDS, remember with ARDS, the whole problem is that the patient has an increase in permeability of their pulmonary arteries, so fluid is leaking out all over the place. For these patients, a lot of times their CVP is down because they're actually hypovolemic because of the fact that they don't have enough fluid in their vascular space because most of it has been leaked into their lungs. When we look at their cardiac index, we may see that it's up or down. It just depends. We will definitely see that their PA pressures will be up, but their PA pressures will be up because of the fact that they're vasoconstricted. Here's the classic thing you need to know about ARDS, and this is an important thing. One of the most common reasons why we put a swan in somebody is to differentiate CHF that's caused by cardiogenic pulmonary edema from non-cardiogenic pulmonary edema, which is just another way of saying ARDS. Here is the hallmark. If the patient has pulmonary edema because of left ventricular failure, then their left pressures are going to be high. Because their left pressures are high, their wedge is going to be high. If the patient has pulmonary edema because of ARDS, they are going to have a normal or a low wedge. I'll say that again. The patient with ARDS is going to have pulmonary edema, but yet have a low or a normal wedge. And the classic thing that we say is the wedge is less than 16. If you've got pulmonary edema so bad that I can hear it with the stethoscope, if that pulmonary edema is cardiogenic, your wedge is going to be way up. It's going to be like 20s, 30s, 40s. If you've got pulmonary edema so bad I can hear it with the stethoscope, but yet I put in a swan and I see that you've got a wedge that's less than 16, that is not CHF, that is not cardiogenic pulmonary edema, that is pulmonary edema caused by the leaking of capillaries, which we know is ARDS. Finally, the last type of hemodynamic alteration that we see very commonly is sepsis, and let's talk about sepsis for just a few minutes. When we talk about sepsis, remember in sepsis there's actually two phases. There's a warm phase and there's a cold phase. When we talk about the warm phase, it has a very unique hemodynamic profile to it. When we're in the warm phase of septic shock, remember that what's happening is the body is responding to inflammation, and as it's responding to inflammation, it's releasing these things called endotoxins. Endotoxins do two big things to the circulatory system that cause the hemodynamic profile that we see. The first thing that endotoxins do is they cause massive vasodilation. So since the patient is massively vasodilated, what is their SVR going to be? It's going to be low. Well, normally when the SVR is low, that also means that all of our pressures are low, and it also means that our cardiac output is low. But in sepsis, as those endotoxins are running through the body causing massive vasodilation, they're also doing one other thing. The endotoxins are actually inotropes and chronotropes in and of themselves. So they push the heart into overdrive. So they make the heart beat harder, beat faster. So the heart is beating harder, the heart is beating faster, so your cardiac index is actually up. And there is only one type of shock where we have a high cardiac index and a low SVR, and that is sepsis. So the hallmark of the warm stage of septic shock is the patient has a high cardiac index, a low SVR. Anytime you see high cardiac index, low SVR, you need to think the patient is in sepsis. Now, the big thing you need to know about sepsis, though, is as the sepsis continues on, what we eventually see is those endotoxins burn off and we move into a cold stage of septic shock. When we move into a cold stage of septic shock, two things happen. One of the things that happens is all that fluid that has been displaced is now outside the vasculature, so now we are in effect hypovolemic. So we actually may see in the cold stage of septic shock that the hemodynamic profile we see is actually a hypovolemic hemodynamic profile, so we may see that everything is low, SVR is up. The second thing that can happen as we move into that cold stage of septic shock and all those endotoxins burn off is we can actually become a victim of something called myocardial suppressant factor. Remember, what myocardial suppressant factor does is it literally limits the heart's ability to contract and to increase rate. And in that case, then we may see what looks like left-sided cardiogenic shock. So for those patients who are in the cold stage, they may present as being in hypovolemic shock, or they may present as being in left-sided cardiogenic shock. But when we talk about the warm stage of septic shock, the hallmark of the warm stage of septic shock is the high cardiac index, low SVR. Okay, let's look at a couple of scenarios right now. Let's actually take some of this and put it into play. So let's say that you're taking care of a patient. He's a 56-year-old male. He just had a CABG, and he's got a steadily decreasing blood pressure. When we look at his current vitals, he's got a heart rate of 110. His blood pressure is 80/40. He's breathing 22 times a minute, and his SAT is 91%. When we look at his hemodynamics, he's got a CVP of 0, his cardiac index is 1.4, his PA pressures are 10/4, his wedge is 3, and his SVR is 1800. So let's think about this. This guy just had a CABG. So what are our most likely suspects for hemodynamic alterations? Well, if we think about this, it's probably going to be cardiogenic shock, or it's going to be what? Hypovolemic shock. Remember when we were talking about managing cabbages, we said the number one reason why patients are hypovolemic when they have a cabbage or in their post-cabbage phase is because they're dry. So let's look at this. If it was cardiogenic shock, if it was left-sided cardiogenic shock, what would the cardiac index be? It would be low. But what would our wedge be? We know if it was left-sided heart failure, our wedge would be high. Now what if it was right-sided failure? If it was right-sided failure, what would our cardiac index be? It would be low, but what would our CVP be? Our CVP would be high. So is this probably cardiogenic shock? No. Okay, we said the other big suspect was hypovolemic shock. If we were in hypovolemic shock, what would our CVP be? It would be low. What would our cardiac index be? It would be low. What would our PA pressures in our wedge be? They would be low. What would our SVR be? It would be high. So this is a classic example of hypovolemic shock. So what do we need to do for this patient? Well, obviously we need to fluid resuscitate this patient. This patient needs crystalloids, or they need albumin, or they need blood, or some other volume expansion. This is a classic picture of hypovolemic shock. Let's look at another one here. Let's say you've got a 59-year-old male who's intubated in the ED for shortness of breath and hypotension. When you go to take care of him, he's currently intubated. He's got the following vitals. His heart rate's 92. His respirations are 12/4. His blood pressure is 92/48. His pulse ox is 93%. So heart rate's 92, ventilator set at 12. The patient's overbreathing the breath by 4 breaths a minute. The patient's overbreathing the vent by 4 breaths a minute. Blood pressure is 92/48, SAT is 93%. When we look at this patient's vital signs, his CVP is 18, his cardiac index is 1.2, his PA pressures are 48/29, he has a wedge at 27 and an SVR at 2100. So let's think about this. What would cause the patient's cardiac index to be low, but his PA pressure and his wedge pressure to be high? Left-sided failure, right? If my left ventricle is not doing its job, cardiac index is going to be low, and what's blood going to do? It's going to back up into the left atrium, and then it's going to back up into the lungs. And we already know from multiple discussions about this that the wedge is just a reflection of the left ventricular end diastolic pressure. So when we see alone that the wedge is high, that in and of itself is pretty diagnostic for left ventricular failure. Now we see this patient's CVP is high. Why is their CVP high? Well, because their wedge is so high that blood is even backed up into their right side, and they've also got right heart failure as well. This is the classic quintessential example of cardiogenic shock. This is a classic cardiogenic shock. This patient's got a high CVP, low cardiac index, high PA pressures, high wedge, high SVR. So what are we going to do for this patient? Well, his blood pressure is 92/48, so it goes back to our discussion. Is this decompensated CHF, or is this truly cardiogenic shock? If we had evidence that there was shock there, i.e. the patient's got a metabolic acidosis, the patient's got lactic acidosis, then we know that this is definitely cardiogenic shock. If we don't have those things, despite the fact that the patient's blood pressure is not the best, if the patient is not developing metabolic acidosis, is not developing lactic acidosis, then this is probably just decompensated CHF. And that's really important because it's going to guide our care. If the patient is just in decompensated CHF, one of the things that we may try for this patient is we may actually try to put this patient on a drug like dobutamine. By putting him on dobutamine, we would increase heart rate strength, we'd improve contractility, and we would also vasodilate the patient, which would decrease their SVR, which would make it easier for their heart to get blood out. That may make this patient better, it may not. So we would start the patient on dobutamine and kind of see what happens. In contrast, if this patient has clear and convincing evidence of cardiogenic shock, if this patient's got the metabolic acidosis, the lactic acidosis, we know we can't go down on the blood pressure anymore. We are stuck between a rock and a hard place. So this patient basically needs a balloon pump or an LVAD, or this patient needs immediate correction if there's the ability to immediately correct whatever is causing the cardiogenic shock. So for instance, if this patient is having an active MI and we can take him to the cath lab and reperfuse him and get that heart working again, then that's the easiest way to reverse this. Okay, let's look at another one here. This actually is very familiar sounding. 59-year-old male, intubated in the ED for shortness of breath and hypotension. Currently he's intubated with the following vitals. His heart rate is 118, his respirations are 12 over 10, so he's on the vent at 12 breaths a minute. He's overbreathing the vent by an extra 10 breaths a minute. His blood pressure is 80 over 31 and his pulse ox is 87%. So when we look at his hemodynamic profile, we see his CVP is 2, his cardiac index is 6.4, his PA pressures are 34 over 16, his wedge is 6, and his SVR is 400. Well, what did we say was the only type of shock where we would see a high cardiac index and a low SVR? Remember, that was septic shock. This patient is the quintessential picture of septic shock. This patient's got a high cardiac index, low SVR. So for this patient, the very first thing we need to do for this patient is we need to tank him up with fluid. We need to get his CVP up. And if you look at our guidelines for sepsis, we say we typically want to shoot the CVP up to somewhere around, somewhere between like 8 and 12, unless he's intubated, which he is intubated. So actually for this patient, we would actually want to give him enough fluid to push his CVP up to somewhere around 12 to 15. The other thing that we're going to have to do for this patient is we're going to have to put him on vasopressors. And when we look at the reason why he's hypotensive, we know that it's because of the fact that he's massively vasodilated. So what would be some good pressors to use for a patient who's massively vasodilated? Well, the answer lies in our alpha drug. So this is a perfect example of a patient who would do well to be on something like a Levophed or Neosynephrine or something like that. The other drug that we use for these patients as a second-line agent is vasopressin for its vasoconstrictive type effects. But the big thing we're going to have to do for this patient is take him up with fluid, and then the next thing we're going to have to do is we're going to have to increase his SVR. Now, when we look here at his pulse ox is 87%. He's massively overbreathing the ventilator. And we said that he came in with shortness of breath. When we look at this patient, the other thing that this hemodynamic profile tells us is the patient also has ARDS. Remember the classic thing we said with ARDS, the hallmark of ARDS is the patient who's in pulmonary edema with a normal or low wedge. If the patient's in normal or low wedge, but they're in pulmonary edema, that's ARDS. So from this patient's hemodynamic profile, we know this patient has sepsis. We also know this patient has ARDS. So not only are we going to have to manage his fluid and his pressors, we're also going to have to put this patient on PEEP. We're probably also going to have to invert this patient's ratio in order to adequately oxygenate him and do all that stuff that we talk about in the respiratory section. So obviously a very sick patient. Okay, let's look at another one here. You've got a 26-year-old male who comes in. He's been involved in an MVC head-on. When he presents, he's unresponsive, he's intubated, he's hypotensive. When you go to take care of him, he's already had 3 liters of crystalloids. He has a heart rate of 48. His respirations are 14 over 0, so he's not spontaneously breathing at all. His blood pressure is 76 over 24, and he's so hypotensive you can't even get a pulse ox on him. When we look at all of his pressures, we stick a swan in him. We see his CVP is 1. We see his cardiac index is 1.7. We see his PA pressures are 12 over 6. His wedge is 6, and his SVR is 300. So when we look at this patient, initially you think he's a post-MVA patient, he's hypotensive. What's the first thing that we think of? We think of hypovolemic shock, right? Well, when the patient's hypovolemic, what would we expect their CVP to be? We would expect it to be low. What do we expect their cardiac index to be? We expect it to be low. What do we expect their PA pressures and their wedge to be? We expect those to be low. But if the patient is in hypovolemic shock, what do we expect their SVR to be? We expect that patient to have a high SVR. This patient has a very, very low SVR. And anytime we have a low SVR, we always know that's a distributive shock. So a patient who's hypotensive, relatively bradycardic, and has a low SVR, what do we think for the head-on MVC patient? We think spinal shock. This is the classic picture of spinal shock. This patient has spinal shock because they're massively vasodilated, because they're hypotensive refractory to fluids, and the hallmark of this is the fact that they're bradycardic. There is no good reason for a hypovolemic 26-year-old male to have a heart rate of 48 when his blood pressure is in the 70s. You'd expect a 26-year-old male with a blood pressure in the 70s to have a heart rate of like 140, 150, 160. So this patient is absolutely bradycardic. And we know that hypotension with bradycardia in the setting of trauma always tips us off to the potential for a spinal cord injury. When we stick a swan in this patient and we see all his pressures are low and his SVR is low, that proves the distributive shock, that proves that this patient has got a spinal cord injury. So what do we do for it? Well, we've already tanked the patient up with fluid. We could continue to give the patient a little bit more fluid, but the big thing we're going to have to do to manage this patient is we're going to have to put him on vasopressors. So since this is a distributive shock, we go back to our best choices. So for this patient, again, good things to give this patient would be things like Levophed, neosynephrine, drugs like that that are going to cause an increase in their SVR. Another drug that actually may be a very good choice for this patient is actually dopamine. Because for this patient, the dopamine, if we put them on medium doses and get kind of really close to that medium-high range, if we get, say, in the 8 to 10 mics per kilo per minute range, we're going to get some beta stimulation, which may or may not increase the heart rate. But the big thing we're going to get is we're still going to get the alpha stimulation that is certainly going to vasoconstrict him. Okay, last one here. You've got a 56-year-old male that presents to the ED with substernal chest pressure and hypotension. He's got a heart rate of 56. His blood pressure is 82/38. His respirations are 18, and his SpO2 is unreadable. Okay, so if you've got a 56-year-old guy who comes into the ED with substernal chest pressure and hypotension, what's the first thing we think of? We think of MIs, right? And what kind of shock do MIs cause? Cardiogenic shock. Remember when we talked about cardiogenic shock, we said we had two kinds. We had right-sided cardiogenic shock and left-sided cardiogenic shock. Let's look first at left-sided cardiogenic shock. If the patient was in left-sided cardiogenic shock, what would his cardiac index be? It would be low. What would his PA pressures and his wedge pressure be? They would be high. So this patient doesn't have left-sided failure. If the patient had left-sided failure, we would see that the PA pressures and the wedge would be high. This patient's PA pressures and wedge are low. Well, what about right-sided failure? If the patient has right-sided failure, what is his cardiac index going to be? Well, if there's not any preload to the left side, his cardiac index is going to be poor. He's going to have a terrible cardiac index. Because he's got a terrible cardiac index, what's his SVR going to be? Well, he's going to vasoconstrict. That's what people do when they're hypotensive. What's his CVP going to be? His CVP is going to be high. This is a classic example of right-sided cardiogenic shock. This is the quintessential example of right-sided cardiogenic shock. This patient's got a high CVP, but his cardiac index, his PA pressures, and his wedge are all low. His SVR is high. This patient has right-sided failure. And remember from our discussion of right-sided failure, we said it's important we identify right-sided failure because we treat right-sided failure exactly opposite of the way that we treat every other kind of failure. If it's right-sided failure, instead of focusing on preload reduction like we do with left-sided failure, with right-sided failure, we're actually going to focus on preload augmentation. So we want to get this patient's CVP nice and high. We want to give this patient a bolus of fluid. This patient's CVP is already 20, so we probably couldn't give him a bunch more fluid. We might give him some more fluid, but the big thing that we need to do is we need to augment the circulation and the contraction of his right ventricle. So after we give him some fluid, the big thing we're going to do is we're probably going to end up putting him on a drug like dobutamine to improve cardiac output from the right side to the left side in hopes of actually improving his left-sided output. Okay, let's take a break here. When we come back, we'll finish up our discussion of cardiac by talking about hemodynamic monitoring, by talking about palliative measures and balloon pumps and all that good stuff. In the interim, I hope that you have a great day, and I will talk with you soon.
I'd come for you, no one but you. Yes, I'd come for you, but only if you told me to.